Welcome to the section of cardiology. This is Dr. Jaitly. I'm going to be talking to you in this video presentation on what is pericarditis. Remember, the heart, like any other organ, is surrounded by an inherent sac, or a covering as we call it. And that sac obviously has two layers. One is the parietal layer, which is the outer covering, and the other is the visceral layer, which is adjacent to the myocardial wall. So two layers, visceral layer, which is adjacent to the myocardial wall, right? I'm showing here in the right panel here. And the parietal layer is a little outside, which is mostly acellular, more fibrous, more elastic. And of course, the visceral layer is more mesothelial in origin. And that is lined by active cells, which secrete some fluid. So normally there is a presence of fluid, and the purpose of all this is primarily to make sure there is a good lubrication because of the movement within the heart. So there is some fluid normally present within the parietal and the visceral layers, and that's roughly about 50 cc's. Beyond 50 cc's is considered as abnormal, so just remember that. So less than 50 cc's is pretty good. And that's the amount of serous fluid that's contained within the pericardial sac, we call it. Now, any inflammation of this pericardial so-called sac will be called as pericarditis. Inflammation is itis. Okay, so obviously the first cause is obviously infection. You want to see viral infections like Coxsackie, Echo, HIV, CMV, which have a predilection for the pericardial area. Cytomegalovirus, HIV virus, Coxsackie, and Echo virus. By the way, there's something called an Echo virus as well. Bacterial is classically a mycoplasma, which is an atypical organism. Staphylococci and streptococci, they have predilection for this area. And Mycobacterium tuberculosis, that causes hugest of the hugest pericardial effusions we have seen, or even constrictive pericarditis, which we will talk about at a different time. So there is presence of Mycobacterium tuberculosis in some of the largest effusions one sees, and specifically in developing countries where tuberculosis is still very prevalent. Fungi and parasitic, just to complete the list, but they are rarely present and obviously only in certain endemic areas. Neoplastic, primary, as I said, is originating from the mesothelial lining, so that's called mesotheliomas. But metastasis, there is predilection from the lung, the adjoining neighboring organs, the breast, the pleura. Melanomas and lymphomas and leukemias are also very, very notorious in migrating to the pericardial areas. So there is a list of metastases that can be suspected if you see it on the chest X-ray or an echo or an MRI. Renal failure is a common cause of pericarditis, especially patients who are, especially patients who are on dialysis. Hypothyroidism also tends to accumulate a lot of fluid around the heart, and it's more of pericardial effusion than pericarditis. Amyloidosis can cause effusion and pericarditis. And then there are traumatic and iatrogenic devices as well. So penetrating injuries, blunt injuries can result into pericarditis, and so can, say, a PCI or a procedure that was done, a pacemaker that has been placed in, that can cause pericarditis as well. Symptoms are usually suggestive of very severe chest pain that's localized, very abrupt in onset, and it's normally preceded by a viral prodrome, obviously because of the above etiology or the causes. It's normally positional. It gets better when the patient sits up. It worsens when the patient lays down. And it's pleuritic. In other words, it tends to have some respiratory component to it, that during the time when the patient takes a deep breath, it hurts more, etc., etc. It could be positional as well, as I said. And then if somebody auscultates with a stethoscope, you could hear 2 or 3 components of a pericardial rub, in addition to the heart sounds that one hears on the chest. Diagnosis is usually by an EKG or an echo or and a CT or MRI in very specific cases, but an EKG will suggest a tachycardia, which is obviously present because of the above reasons. But PR depression, which is here I've shown in this left side of the panel. Now this is a normal complex, and you see how the interval between the P and the onset of R wave, and the Q is somewhere hidden here, but PR, the end of P and the beginning of R, that's where there's depression. Here this depression this was isoelectric, there was no depression here, and here you have a depression. So when you have a PR depression present, and then you have an upward concavity of an ST elevation. So here you see how from the baseline the ST is elevated and there's an upward concavity as opposed to upward convexity. Now when you see an upward convexity, that means during the ST elevation, when you see an upward convexity, that is a marker of ischemia, sine qua non of ischemia. But an upward concavity is a sine qua non of pericarditis on an electrical complex. So very, very subtle changes on the EKGs, just make a note of that, and these are very, very classic changes of pericarditis, PR depression and upward concavity for pericarditis and upward convexity for ischemia or infarction. Now, echo will show usually a pericardial effusion if it is present, and it's very sensitive. So any amount of effusion that's present will be seen on an echo right away. And its echo is also very helpful in understanding the hemodynamics, specifically so if there is a tamponade or pericardial tamponade that's suspected. What happens is the pericardial sac can accumulate fluid at a rapid rate, either in viral origin or traumatic origin or metastatic in origin, etc. And that fluid will ultimately compress within the ventricles and the atria. And as a result, that's hemodynamical compression of the fluid's presence within the pericardial sac, leading to a compromise in the function of the left ventricle and the right ventricle and the entire cardiac output, is considered to be pericardial tamponade. So those hemodynamics are very, very important, and we'll discuss that at a different time when we discuss echoes. But for now, just remember echo is very helpful in knowing if there's an effusion present, as well as if there's a tamponade suspected. Sometimes constrictive pericarditis has thickened, calcified areas of the pericardial sac or pericardial layers can be seen. But otherwise, CT or MRI are very, very diagnostic of constrictive pericarditis. Okay. Thank you for your attention, and let's talk more later. Hope you enjoyed this section. Bye.